Welcome to the Explainer. If you're a surgeon or a gastroenterologist, you already know that GI screening landscape has totally transformed lately. Today, we're unpacking the much-anticipated 2026 Korean guidelines for managing asymptomatic upper GI subepithelial lesions, or SELs. We're going to look at the shift away from routine surgeries and dive into EUS-based risk assessment, targeted tissue acquisition, and those amazing state-of-the-art resection techniques. Let's get right into it. Here's our clinical roadmap. We'll be hitting the asymptomatic SEL challenge, EUS-based risk assessment, advanced tissue acquisition, modern endoscopic resection options, and wrapping up with the new 2026 management algorithm. Section 1, the asymptomatic SEL challenge. So, resect or observe. This really hits the nail on the head when it comes to the modern clinician's daily dilemma. You're doing a routine scope, and boom, there it is. A smooth, asymptomatic bump under totally normal-looking mucosa, an accidental find. And you instantly have to ask yourself, do we resect this or do we just watch it? We know most of these are totally benign, but sitting right there in the back of your mind is the very real threat of a GIST or a neuroendocrine tumor. And it's definitely not a rare scenario. Current data shows these SELs pop up in about 0.3 to 3.0% of all upper GI endoscopies. With national screening programs ramping up everywhere, you're literally going to see these all the time. The stomach is the most common spot, followed by the esophagus and duodenum. So getting a rock-solid, evidence-based approach lockdown is absolutely crucial for our day-to-day practice. Moving on to Section 2, EUS-based risk assessment. Okay, so this right here is the turning point. This is where we officially drop the old let's just resect everything in case mindset and step into precision medicine. Endoscopic ultrasound is the absolute cornerstone here. Looking at the EUS characteristics, you can clearly see how it delineates risk. EUS lets us peek right under that normal mucosa to figure out the exact layer of origin. So if you see smooth margins, a homogeneous look, and a hypercoic lesion in that third layer, you're probably just looking at a benign lipoma. But if you see irregular margins, it's over 3 centimeters, or you spot cystic spaces or echogenic foci, that's when the alarm bells should be ringing. Those high-risk features strongly point to a potentially malignant GIST or NET, and that demands immediate action. We have some fantastic recent perspective data that illustrates the natural history of these small lesions. Look at this. A whopping 92.1% of these lesions stay completely stable during long-term follow-up. But that remaining 7.9%, so about 1 in 13, will show interval growth or actually need resection. So this data totally validates active surveillance for small, low-risk lesions, but it also highlights exactly why we need vigilant risk assessment to catch that 7.9% before they progress. Section 3, advanced tissue acquisition techniques. Well, what happens when you do spot a high-risk feature or notice growth? Let's address the elephant in the endoscopy suite. Standard forceps biopsies are just notoriously awful for these lesions. They give you a diagnostic success rate of only 40.6%. And why is that? Because the forceps are just grabbing that superficial, healthy mucosa, completely missing the subepithelial layer where the actual tumor is hiding. Even bite-on-bite techniques usually fall short and just end up increasing bleeding risks. We need the right tools to dig deeper. And that's where choosing the right advanced technique comes in. On the one hand, we've got EUS-guided fine needle biopsy, or EUS-FNB. With an 84.2% diagnostic yield, it is phenomenal for larger lesions. It gets you that crucial core tissue for immunohistochemistry and mitotic index for GISTs. But what if the lesion's tiny? Under 20 millimeters, needles tend to deflect or just completely miss because the lesion rolls away. That is exactly where MIAB, or mucosal incision-assisted biopsy, comes into play. It has a stellar 88.2% yield. With MIAB, you actually incise the mucosa to directly expose and biopsy the lesion. It's a total game changer for those incredibly frustrating, tiny yet suspicious nodules. Section 4, modern endoscopic resection options. So once you've got a diagnosis, it's time to take action. This is where we pivot to those minimally invasive marvels that are rapidly replacing old-school surgeries. First is ESD, endoscopic submucosal dissection. By dissecting the submucosal layer right under the lesion, ESD lets us do an en-bloc, or one-piece resection. That is huge for a complete cure and gives your pathologist perfect margins. It's awesome for small gastric GISTs or NETs that don't go deep into the muscularis propria. But, it does demand a ton of technical skill because the bleeding and perforation risks are definitely real. Next up is STIR, or submucosal tunneling endoscopic resection. This technique is honestly just so elegant. You make a tiny mucosal cut a little ways away from the tumor, literally tunnel your way through the submucosa, resect the tumor from the muscle layer, pull it out, and then just clip the entry point shut. Because it preserves that overlying mucosa, it's a brilliant fix for lesions in the esophagus or gastrocardiolis, like leiomyomas. It's wild that we can now navigate entirely within the walls of the GI tract itself. And finally, what about those really tricky lesions, the ones deep in the muscularis propria or growing outward from the GI tract? For those, we have EFTR, endoscopic full thickness resection. Back in the day, these automatically meant a surgical wedge resection. But today, using advanced over-the-scope clips and suturing systems, we can deliberately cut straight through the entire GI wall, pop the lesion out, and safely stitch up the full thickness hole entirely from the inside. It is a massive leap forward in therapeutic endoscopy. Section 5. The 2026 Management Algorithm. Okay, so how does this all come together? If you look at this 2026 algorithm, you'll see the main branch points are entirely dictated by size and US findings. See on the left? Asymptomatic lesions under 1 centimeter with 0 high-risk features, they just get routine endoscopic surveillance. But look on the right. If a lesion has high-risk features like irregular borders or if it hits that 2-centimeter mark, the whole pathway aggressively shifts. It immediately mandates a real tissue diagnosis with FNB or MIAB, and then it smoothly funnels you down toward targeted endoscopic or surgical resection if a GIST or NET is confirmed. Let's just distill that giant flowchart into a super quick mental checklist for your next shift. Step 1, identify the asymptomatic lesion. Step 2, immediately bring in EUS to check the exact size and hunt for high-risk features. Step 3, if it's 2 centimeters or larger or you see those high-risk EUS signs, skip the standard biopsy. Don't even bother. Go straight for FNAB or MIAB. And step 4, if pathology comes back confirming a GIST or NET, deploy your advanced resection toolkit, ESD, STIR, EFTR, or surgery, tailoring it perfectly to the lesion's size and depth. And really, this all boils down to the core philosophy of the 2026 guidelines: selective intervention rather than routine resection of all SELs. The days of doing blind surgical wedge resections for every single subepithelial bump are totally over. By leaning on high-res EUS and advanced tissue sampling, we can confidently leave the benign stuff alone, saving patients from unnecessary surgeries while zeroing in on the ones with true malignant potential. Which leaves us with a big question for all the clinicians watching. The tools are here, the data is clear, and the guidelines are set. So how quickly can you integrate EUS-guided selective intervention into your own practice and update your institutional protocols? The shift to minimally invasive, highly targeted management is happening right now. I really hope this explainer gave you the structural clarity you need to tackle your next asymptomatic SEL with total confidence. Keep learning, keep evolving your practice, and we'll catch you on the next explainer.